Hello and welcome to this educational session on adrenal crisis. So this is just going to be a quick review through the care map E05 adrenal crisis just to understand what it is and how we can treat it. So like I said here, so this is the actual care map in itself. It's not huge, but it's good to know what we're doing. So adrenal crisis itself refers to acute adrenal insufficiency. It's a possibly life-threatening emergency characterized by shock that requires treatment with corticosteroid replacement and possibly large volumes of fluid. So with that, to access this care map, we need to have a patient with suspected acute adrenal insufficiency with known chronic adrenal insufficiency or an abrupt cessation of their corticosteroid use. So either they're non-compliant with their medications or they've run out. But either way, we're going to have a previous diagnosis of this issue. We're not expected as paramedics to go into a house and diagnose someone with adrenal issues or Addison's disease. That's not an expectation. So to access this care map, we're going to have to kind of look into a patient's history to get an idea of what we're dealing with. And there's really no contraindications using this care map. Obviously, if this is not something we're suspecting in our patient or they don't have a history that would guide us to this, we're not going to access this care map. So when we talk about adrenal crisis, a lot of times we reference patients that have Addison's disease. So Addison's disease is also known as primary adrenal insufficiency. So this is a primary disorder of the adrenal glands themselves. So adrenal insufficiency is a disorder that occurs when adrenal glands don't make enough of the hormone cortisol and sometimes aldosterone. So we look at cortisol, it's most commonly known as the body's stress hormone. It has a wide variety of effects throughout the body. It's also the main glucocorticoid released from the adrenal cortex. So this hormone affects almost every organ in the body. It regulates your stress response, your use of fats, proteins, and carbohydrates in the body. And so basically it controls your entire body's metabolism. It helps suppress inflammation. It helps regulate your blood sugar, your blood pressure as well, and it controls your sleep-wake cycle. So you can see if something is going on with the cortisol and it's not being produced effectively, it can have a lot of wide range effects on your body. The other hormone we're looking at here is aldosterone. So this also comes from the adrenal glands and helps to regulate blood pressure by managing your sodium and potassium levels in your blood. So we could look at secondary hypoadrenalism, and this is an issue in the pituitary gland. So secondary adrenal insufficiency occurs when the pituitary gland doesn't make enough of the hormone ACTH, or adrenocorticotropic hormone. And with that, a reduced production of ACTH results in the adrenal glands not making cortisol. So if the pituitary gland's not making ACTH, it's not telling the adrenals to make cortisol, and problems can happen. And then tertiary hypoadrenalism. So this actually takes place in the hypothalamus itself. Usually this happens because of an issue with the hypothalamus. So it could be like disease, cancer, tumors, or trauma itself. So something's wrong with hypothalamus. And with that, it may be altered. It may alter its ability to release CRH, or corticotroponin releasing hormone. So that's a hormone that tells the pituitary gland to make ACTH. So they all kind of work in there together. So when we look at the big picture here, we have the hypothalamus that releases CRH. The CRH tells the pituitary gland to release ACTH. The ACTH then tells the adrenal glands to create cortisol, which has a lot of effects throughout our body. So if there's a breakdown in any different steps of this process, we can have issues creating cortisol and potentially put our patient into adrenal crisis. So with that, the big thing that can really cause a lot of crisis for our patients as well is just stress. Because again, if their adrenal cortex is just not able to make enough cortisol to meet demands, and also unknown stress can be put on the body, it can put our patients into crisis. Also with that as well, just like we said in the indications, if they're not taking their corticosteroids, they missed a dose, they ran out, they forgot, things like that, that can cause a crisis situation as well. So common stressors that we look at that can put our patient into this crisis is we could look at dehydration, infections. So like if they've got a really bad flu, sepsis, things like that, UTIs. And pregnancy can really do this to moms as well. So if they have pregnancy, and especially in the third trimester, puts a lot of stress in their body, which can cause them to go into adrenal crisis. Time of emotional, mental stress. So if they've like had a loved one die or they're going through a lot of personal issues at the time, that can cause an increased stress load on the patient, which their natural cortisol levels cannot meet and put them into crisis. And we also consider our trauma patients, right? If they just had a car accident and they're all smashed up upside down on the side of the highway, that is a lot of stress in their body, which their body may not just be able to handle it more. So with that, that can also put our patients into adrenal crisis. So if we're responding to these patients, we have to be very concerned that we have our primary all the stress on the body to deal with, but we also may have to deal with adrenal crisis on top of that because of that extra stress being put on our patient's body. So some signs and symptoms of adrenal crisis. So one of them is nausea, vomiting, anorexia. So with that, corticotropin-releasing hormone, or CRH, is a potent appetite suppressant in response to stress. So during an adrenal crisis, the release of CRH remains uninhibited. So basically, it takes away your hunger. So these patients are not going to be hungry. They're not going to feel like they need to eat. So it can lead to states of anorexia where they're just not having that oral intake because their body's basically telling them they don't need to. So abdominal pain and digestive manifestations are thought to be of a direct consequence of glucocorticoid and mineralocorticoid deficiency. So they might be complaining of abdominal pain. So weakness and fatigue, this is just straight up from your lack of cortisol, because again, it regulates your awake sleep cycles. And of course, that might be off. They may not be sleeping. They may be really tired and fatigued because of their cortisol levels. So lethargy, confusion, coma, again, that could just be from lack of cortisol as well. Hypotension. So this is going to be a big one because this can be life-threatening. So we look at patients with adrenal crisis and hypotension. These patients often experience hypotension. In some severe cases, they may develop profound shock that remains unresponsive to fluid resuscitation and vasopressor therapy. So during an adrenal crisis, any significant stressor can trigger an uncontrolled cytokine response, which causes inflammation. So this cytokine response can also cause fever, widespread vasodilation, heightened capillary permeability. So obviously that's going to cause fluid shifting. So this can all result in hypovolemia and shocks, the consequence of fluid shifting from capillaries into tissues, and therefore helping lower the blood pressure. So basically, during an adrenal crisis, the dysregulation of the immune response, marked by an excessive cytokine release, can result in systemic inflammation, fever, vasodilation, capillary leakage, hypovolemia, and shock. So this hypotension can be very severe and it can be life-threatening. Dehydration as well could be a big issue, and that could help make the hypotension worse because if they're dehydrated because they might be urinating a lot, because they do find in these patients they have increased diuresis. They might already be volume depleted, and now they're hypotensive because of all the issues we just talked about. This can put your patients into even a worse crisis as well. And hypoglycemia can occur just because they may not be producing enough glucose production in themselves. Also, like I said before, if they have that anorexia where they're not taking any oral intake, that may itself just lower their blood sugars. So we always want to check these patients for hypoglycemia as well. And of course, electrolyte imbalance. So in primary adrenal insufficiency, aldosterone deficiency leads to volume loss, hyponatremia, and hyperkalemia. So with these patients, we definitely want to put them on the monitor, check them for hyperkalemia, because again, like these patients can be complicated. So like I said, they may have something that's actually stressing them out that puts them in an adrenal crisis. They start developing hyperkalemia, hypoglycemia. These can be very sick patients. So we want to make sure we do very thorough assessments on them and put them on the monitor. So with that, we're just going right back to E05 here at the top of the care map. Just like anything, if they're in a crisis, we want to make sure they have a good airway and they're breathing properly. And if they need help, we can give them assisted oxygen or assisted ventilation. So good old ABCs. So we want to get IV access sooner than later because, again, if they're in crisis, we can get that severe hypotension. So if they're not hypotensive yet, we probably want to get an IV as soon as we can. So that way, if their blood pressure does start dropping, we can start fluid therapy and steroid therapy as soon as possible. Next thing we're going to look at is giving hydrocortisone. So if we look at med profile M13 hydrocortisone, it gives us the indication that known or suspected acute adrenal insufficiency patient with known chronic adrenal insufficiency. So again, if we're going to give hydrocortisone as a therapy for our patients, we're going to have to get a bit of history beforehand. This isn't one of those ones where someone's just going to be laying there unconscious, nobody knows them, and we're going to be able to figure out that they have Addison's disease on their own. So we kind of need to get a patient history to go this direction. And there's no contraindications because, again, if they don't meet any of the indications, we're just not going to use this. So when we give hydrocortisone, it provides emergency replacement of cortisol for patients whose adrenal glands do not produce appropriate levels of adrenal hormones. So the nice thing is for adrenal crisis, it can be given IV, IM, or sub-Q because, again, it might be very hard to get an IV on these patients if they're already hypotensive. The nice thing as well is we can also assist patients in taking their own medications, such as prednisolone or dexamethasone. We can assist them taking theirs. They don't necessarily have to take ours. If they have theirs ready to go and they just need our assistance, we can do that for them as well. So when we look at giving subcutaneously, we're going to be doing our weight-based dosing, and our max is 100 milligrams of dose. For most of the vials that we use, it's going to be 100 milligrams per ml. So the nice thing is when we give it IM or sub-Q, we can do that because it's 1 ml. So if we are going to give it sub-Q, we're going to be using our same 1 cc syringes with the needles in them that we use for enoxaparin, because those go up to 1 ml, so that can allow us to give hydrocortisone this way as well. So if we are going to give hydrocortisone subcutaneously, we can have few different injection sites. So one is the abdomen, so at or under the level of the belly button, about 2 inches away from the belly button. We have the arm as well, so the back or side of the upper arm, or the front of the thigh. So we can do subcutaneous injections there. If that's not where you want to go, we can do intramuscular. And if you have an IV, then we can go IV. So you have some different options there based on what you can access. So again, these are the active vials here. I have a separate video on my YouTube channel about how to use these. But again, just because they can come in different concentrations, different size vials, always check your concentrations before you draw it up, because if it is more than 1 ml, subcutaneous may not be an option for us. And also, if it is like more than 1 ml for IM injections, we're probably going to have to inject in their thigh versus their deltoid. So just make sure you check your concentrations and your dosing before administering it. So after that, we're going to, of course, do vitals, all that good stuff. So we want to make sure that they're not hypotensive. But if we do find that they need fluid resuscitation, again, these patients may need multiple liters of fluid, so you may have to do a lot of rapid fluid admin. We're going to start our fluid resuscitation in bolus 20 mLs per kg, 1 liter at a time. Again, constantly reassessing our patient as we're giving this to make sure it's actually working or not, because again, they may be fluid refractory, so we may not see an instant blood pressure increase with extra fluid. But we also want to make sure we're not fluid overloading these patients either. So we want to make sure we're constantly checking if they are any shortness of breath, any crackling in the lungs, LOC, all those things there. Just keep rechecking their blood pressure. If they're geriatric or pediatric, we might consider starting off with smaller boluses because they might be more at risk, like it says with history of heart failure or dialysis. They may be more at risk for fluid overload. So if we start at 10 mLs per kg, we can always give more versus if we accidentally fluid overload them, we're kind of stuck there. So just some considerations there with our fluid. And like I mentioned before, in the care map says exclude hypoglycemia. So yeah, these patients can totally have low blood sugar. So we want to make sure we do that blood sugar, and we're going to treat as per E10 hypoglycemia. The thing is, though, is that if you have to give your patients multiple liters of fluid, giving D10 does not count towards that fluid therapy. D10 is meant as a therapy for hypoglycemia, not as a fluid replacement. So with that, if you're looking like you need to give a couple liters of ringers or saline to get their blood pressure back up, do D10 separately or piggyback it on top of that fluid. Don't just use D10 as part of their fluid therapy. It's two separate things. D10 is not meant to just replace their actual fluid in their circulation. And of course, we're going to make a transport decision. So we're going to decide which hospital is most appropriate for this patient, whether they have a predetermined destination and the paperwork to go with it, or if it's just closest hospital because they are critical. And that is adrenal insufficiency. Thank you for watching the video and have a good one.